We've got a clinical case. Let's start. Take your pens, papers, and let's go. Be careful, huh? 65-year-old man with a history of hypertension, 65. He started on a new medication, metoprolol. No, it's a beta blocker, for rate control of his newly diagnosed atrial fibrillation. A week later, he presents to the emergency department complaining of severe dizziness and a near-syncopal episode. His blood pressure is 110/70 mercury, 11/7. An ECG, electrocardiogram, is performed and shows a heart rate of 35 beats per minute. 35 beats per minute after atrial fibrillation, with a regular rhythm, that is sinus rhythm, and P wave preceding every QRS complex, but with a very long, fixed PR interval of 360 milliseconds. No, we understand. I suppose the addition of the beta blocker has most likely unmasked or worsened which underlying condition. So we see restoration of normal sinus rhythm, but with problems with PQ or PR interval. So second degree AV block, Mobitz type 2. No, of course. Sixth sinus syndrome. We see normal P regular. No, it's not sixth sinus syndrome. First degree AV block, definitely it is. And third degree complete AV block. No, my beloveds, of course, correct option is the first degree AV block. So the question test the ability to recognize. Actually, it's a tricky question. Anyway, it's a question. So the question tests the ability to recognize a specific type of heart block on ECG, EKG, up to you, K or C, electrocardiogram, and understood how beta blockers can dangerously worsen it. Actually, very rare phenomenon with the beta blockers. Don't prescribe them. So what is the problem? So why I said first degree AV block, I say it's correct, yes. Why it's a correct option? What we see on ECG. Description is a key. A rhythm with every P wave is followed by QRS is a sign of sinus rhythm. But PQ, let it be PR. Actually, most correctly pronounced PQ. Anyway, PR, let it be PR, same thing. But the PR interval is fixed and prolonged. That is more than 200. We've got 360 something, 360 milliseconds. Is the textbook definition of first degree AV block, atrioventricular block. So a PR interval, PQ, is of 360 milliseconds is severely prolonged. But we see sinus rhythm. But just a sinus rhythm and period. And we see AV block first degree. Now about pharmacology. Beta blockers, here is metoprolol, United States drugs, works by blocking the beta-1 receptors in the heart. One of the primary effects is to slow conduction through the AV node, a so-called negative dramatropic effect. So that's why we prescribe that, and it's very good to prescribe. But here we've got a very interesting interaction. The patient likely had a pre-existing maybe asymptomatic tense to first degree AV block with a borderline PR interval. We don't know because we have atrial fibrillation from the beginning. So the addition of beta blocker, which further slowed conduction, plunged the mild block into severe one, actually first restoring sinus rhythm. So this resulted in profound symptomatic bradycardia, a very slow heart rate, causing his dizziness, and this is the logic. So why other options are incorrect, my beloved? Second degree AV block Mobitz 2 in this rhythm. In this Mobitz 2, in this rhythm, some P waves would not be followed by QRS complex. We remember so-called dropped beats, while the PQ interval of the conducted beats would remain consistent. This description states every P wave is followed by QRS. So I repeat, we see restoration of sinus rhythm, but with block. Actually, it's a good question what to do next. Good question. What is next? And next, sixth sinus syndrome. This is a disease of the sinoatrial SA node, and the heart's natural pacemaker, first degree pacemaker, natural. It would typically present with profound sinus bradycardia, sinus pauses, or alternating periods of slow and fast rhythm, so-called tachybrady syndrome, not a specific AV conduction block. Here we've got normalization of sinus rhythm, but with AV block, first degree. which is not a catastrophe at all. And what next? Third degree complete AV block. No, of course, it's a nonsense, the delusion. In this rhythm, there would be complete dissociation between P waves and the QRS complex. No PQ, no PR interval. The atria and the ventricles would be beating independently of each other, and there will be no consistent relationship between them. Because we will see two natural pacemakers working at the same time. So the description states that a P wave precedes every QRS complex. Actually, good question, but tricky one. Anyway, what to do next is a big issue. So anyway, my beloveds, high yield takeaway. Beta blockers must be used with caution in patients with pre-existing AV conduction disease. But we do not know about this pre-existing AV conduction because we do not see his previous ECG. Previous ECG only just atrial fibrillation. So doctor prescribed it correctly. They can turn beta blockers into a benign, it's a benign, of asymptomatic first degree AV block, into this condition as severe one, symptomatic bradycardia. So this is a classic example of how their therapeutic drug can unmask an underlying electrical problem. Well, very good question. Thanks for this question. Got it? Re-listening this video, huh? Stay blessed.